So welcome everyone. It feels like we have been in January for a long time already, but it's actually our first SIG meeting of the year. We love having you participate, and today our topic is going to be the promise, as we promised all of you at the end of last year. But before we do that, we want to give you some updates. We want to begin by introducing the new leadership for this year. You know me because I was the co-chair with Matthew last year, and now we have Rachel, who was our research corner, is going to be the co-chair with me. And then we have also familiar faces that change roles, like Jonathan is now going to take care of the research corner. We continue to have Michelle taking care of all our logistics. Hi, Michelle. And lastly, Amelia is the new team member. Amelia is going to be the engagement role for the SIG, and she's going to tell you about a couple of things today. So I think this is it. If you have job postings, please put them on the chat. We would like to collect that, and then everyone here can see them too. And we want to make another announcement before we move on. The pediatric proposals for the conference have a deadline in March. I don't know if it's March 15, maybe Jackie can confirm that. But March I want 15. 15, okay. I want to encourage everyone to start thinking about, your proposals and maybe teaming up among yourselves and just, get out there. If you have any questions or if you want to ask us, what our thoughts on that, just email us. We're happy to help. We also have, as always, an ELO for pediatrics. So now I'm going to let Amelia, to speak about that.
Yeah, we're really excited for our Extending Learning Opportunity, our ELO, but we kind of wanted to get your feedback on what you guys would be interested in learning more about. So the two topics that we've kind of narrowed it down to are, one, collaborating with school and families on the promotion of resilience in youth, or the other option, number two, being building a pediatric suicide prevention and management toolkit. And I can put this in the chat too, since I said a lot of things, but I would love to hear from you guys about which ones you would be more interested in. So if you're comfortable, send a message in the chat. If you're not comfortable, send me a private message in the chat and let me know which one you'd be interested in. That way we can kind of get an idea of interest level when we're creating our proposal.
Awesome. Thank you, Amelia.
Yeah.
All right, so start chatting anytime. Amelia is going to count that, and then we'll get back to you about what is the winner. So I think now we can move on and start the presentation. Thank you, Ryan, for coming and present the promise to us. We are looking forward to what you have to say about it. So take it away. If you're sharing your screen, you can start doing that.
All right, so welcome. My name is Ryan Jacobson. I'm a pediatric physical therapist. I work in George Fox University in Newberg, Oregon. We've been doing a lot with Promise in pediatrics and adult. In adult, we've also done a lot with Promise in the primary care environment, where we've embedded physical therapists side by side with primary care physicians. And so I guess, just kind of to the nature of what we're doing here today, I'm just going to share how we use it, give you some vision, some examples, just see if I can inspire you for this unfiltered source of health information for our kids. Please chime in if you have questions. I'm super informal because, well, I play with kids and I have a career playing with kids. I mean, I get paid to play with kids, which is just fantastic. And I know my 12-year-old daughter gets tired of that, but so be it. All right, so some of you might have had a chance to kind of preview Promise. Some know what it is. Maybe all you do. Dave Haddock and I sent out some cool stuff about it, and I'll try to kind of recap some of that. But Promise was an NIH-funded initiative in 2004, really got rolling by 2007 through 2010. Promise stands for the Patient-Reported Outcome Measurement Information System. And you can explore it at their intro site at healthmeasures.net. Really usable site, kind of fun. You can even practice and take one yourself, at least an adult measure. So what I thought I'd do is start by showing you how it works. It can be administered many different ways, but I did a video of myself taking 4 PROMIS measures on our iPad, because we use an iPad app through Health Measures. And what you're about to watch is me as if I was setting up the patient to take a life satisfaction measure, a meaning and purpose measure, an anxiety measure, and a depressive symptoms measure. And you're going to kind of just get a feel for how it goes. So here we go. Hit start. Hand it to my patient, and off they go. So the way each question works is a 5-point Likert scale. They're all validated questions. They're asking, in this case, about the last 4 weeks. And what you're going to see is a computer adaptive approach to answering questions. As I go along here, at some point, the IRT model is narrowed to a small enough standard error, and then it finishes with that particular scale. This is high speed now, because I don't want you to have to watch everything at real time. But it's going through all 4 measures. Looks like we're going into anxiety now, and maybe depressive symptoms, and it's done. And so, yes, I sped it up a little bit, but really that took approximately 2 minutes to do 4 measures. The iPad app ends up giving you a readout like this of all the 4 measures. And I'm kind of introducing it now because we'll look at it again with some cool cases. The third column is really where we're interested right now, which is a T-score, and I'll talk about that. And so here you see my T-score results for life satisfaction, meaning and purpose, anxiety, and depressive symptoms, or at least that of the child who took this PROMIS exam. But it's always fun to kind of get a flavor of what it actually looks like. In our clinic and in our primary care partners' clinics, we hand the iPad directly to the patient at the start of care and let them fill it out. If they have questions, we answer them for them. But really, it's kind of their own world of answering without us priming them or even biasing their responses.
And is the way it's administered, sorry, is that the Epic PROMIS module, or is that a separate module?
That's an independent Health Measures app on iPad. The Epic modules aren't quite as UI friendly, but they do work out fine. I mean,
okay.
We've found with partners across the country who do this implementation, at least in hospital-based systems and outpatient clinics, that they'll use some third-party administration app that integrates directly to the EMR. And of course, those big health systems have tech people who can just instantly shoot it in. But the iPad is the most elegant and most user-friendly. And in small clinic, or even when we walk in, like in primary care, when a PT is called in side by side with a physician might stay or step out, and then we'll kind of introduce ourselves and hey, we'd like to get to know a little bit more about what's going on. I know you've talked with the PA about this. Could you fill this out? And that way they just have their own iPad in hand to kind of navigate through.
Thank you.
Yeah. All right, some nuts and bolts here. Oh, I still don't have a cursor. That's too bad. Let me try something here. Oh, look, I have a cursor now. That's good. All right. Thanks for being so casual. All right, so for the nuts and bolts, the PROMIS pediatric measures span physical, mental, and social domains. There are self-report modules down to 8 years of age, and then parent proxy across the age span down to 5. There's some work being done on some of the measures now for validation in preschool ages. It's a separate conversation, but if you ever want to talk about the difference between parent proxy and child self-report in children with long-term disabilities, it's amazingly cool and hard to capture like reality. But there are a variety of ways to administer. As I said, the iPad app directly, Epic and a couple other major EMRs have it fully integrated, and then third-party integrations with EMRs as well. Advantages of PROMIS. If you had a chance to read the DeWalt article, it kind of lays out the 6-step process for validation of every PROMIS tool. There are over almost 400 tools with adult and pediatrics now out there, and each tool is validated using this process or developed, and then the validations have been extensive. Last week, I did a PubMed search just for PROMIS in pediatric, and there's 522 studies, and you can see they're really ramping up in the past few years. So I think PROMIS in pediatrics is steamrolling out there. All the norming and the IRT models and everything is going to continue to be normed to the US 2010 census data. And that keeps consistency even around the world where PROMIS adaptations in other countries are still using this census data. So there's comparability across different countries. There are very minimal floor and ceiling effects. PROMIS was developed so that it could span the range of abilities and capacities and life symptoms. It's also agnostic to disease. So these aren't disease-specific measures. They are anyone and everyone can take them. And then, as I kind of alluded to, it's computer adaptive. The IRT models used with the 5-point scoring, Likert style scoring, really hones most results, like you saw there, to around or under a standard error of 3 T-score points. Just a quick recap or introduction if you're not a stats nerd like me. A T-score is a score with a mean of 50, so that's kind of like the mean for the US population. A standard deviation of 10 points up or down. And then each measure is very specific and has been kind of developed to measure a single trait, either a symptom set or a type of functioning. And so every PROMIS measure does one trait, and that's important for measuring. And the higher the score, so 50, 60, 70, means more of the trait you're measuring. So if you're measuring depression, then a 65 is a very high level of depression. But if you're measuring kind of a positive measure like physical function or a positive affect, then a 65 means more of that good stuff. And so that's kind of a switch for us, like big isn't always good. All right, so let's get down to kind of like, I don't want to call this the sale, because if something better came along, I'd be fully game. But as far as patient-reported outcome measures right now, I'm going to tell you why we think it's super advantaged and why we use it. For the first part, it's unbiased by the provider, which, you know, the minute we come in with a subjective interview, that changes the narrative. It also allows priorities to start to emerge before we've talked with the patient. And then last, it just leads to better decision-making. So digging into each of these, especially related to better decision-making, the first thing we love is that it hones the subjective interview. Here's how. It's like getting intel ahead of time, right? When that patient hands me back the PROMIS iPad, and then I can go through their scores and kind of think, okay, what's really outside the bounds of typical or okay? I have something to begin, you know, my motivational interviewing, or, you know, in a world of behavioral health, you know, if you're a brief act and primary care type person, this is kind of cool to kind of hedge your bets towards something and lead the conversation well, in honor of what the patient's kind of said before you ever talk to them. Also, because you can do so many measures in so little time, like I just did 4 measures on the iPad in under 2 minutes, you can get outside our discipline. Like physical therapists, you know, we always think like, you know, pain and function and mobility, and yet our batteries have fatigue and peer relationships and life satisfaction and sleep related impairment, and we can get all this information really fast. It does turn out that their own priorities are more likely to be revealed. You know how patients can go down a funnel when you start a subjective interview. And honestly, as good as we are as humans and interviewers, we're not perfect. I like this too. It's a great piece of data to triangulate towards diagnosis of what's going on. And then in the world of behavioral change, which is healthcare everywhere and is definitely physical therapy, discrepancies between the scores on the PROMIS and then what's coming out from the patient as they talk with me are really an opportunity for opening up, you know, behavioral change or willingness to change or willingness to consider something else. So let's look at what that might look like. Let's say I have a patient and their kind of subjective jive is, I just feel so down lately. It's not really easy to even get myself out of bed. And with that, let's see where that could come from, because that could be a lot of different things. And if I've administered a PROMIS beforehand and these 4 measures, there's a strong likelihood that this might not be so much a depressive symptoms focused response, but maybe something related to fatigue and maybe something going on in school or life and social roles. And again, you can see with these scores, as we get used to T-scores, you know, with an average of 50 And really, if we're within half, even one standard deviation from that, that's probably not the big player. But this patient right here, her fatigue level is 62, so over a standard deviation more than the US average of kids and teens, and a very low, almost 2 standard deviation drop in her satisfaction with social roles. And so triangulating really helps us get down to the meat and potatoes of what might be going on with our patients. Here's an example of how discrepancy might lead to opportunity. Patients, they don't always tell you the whole thing. And so this boy's like, oh yeah, it's chill. I'm hanging out with my friends lots. And that might be true. But his PROMIS scores say there's really a high degree of anxiety going on right now. And that actually, even if he is hanging out with friends a lot, his satisfaction with that is not going well. And so for whatever he came in for, I can start to kind of like get down to, all right, well, you're saying that hanging out with friends a lot, your score here on the iPad test I just gave you says that your satisfaction with how that's going isn't so great. Is that true? I mean, how does that resonate with you? And, you can get them talking a little bit about that. And that's really an opportunity for kids, patients in general, and even families of younger kids to kind of like, okay, yeah. I think discrepancy is always a great opportunity in physical therapy that often leads to us looking towards kind of a cognitive functional therapy approach of let's challenge some beliefs about either pain or about how you think you can function with disability. And so I love discrepancy between the PROMIS scores I see and the words I'm hearing. So that was kind of the first thing I love about better decision making, just kind of honing that subjective exam. It also helps determine severity, and more of this work is being done. I know I'm glad someone laughed because I like the flame effect on slides. This is from an article I shot out a couple of weeks ago through Maria Mann and friends here not too long ago in 2020. And they took the PROMIS kind of IRT model and all the benchmarks of that, and they made little vignettes. And then clinicians, adolescent patients and their parents age 13 to 17 came in, and they kind of looked at the story of the vignette and decided a bunch of different stories. When does this become a mild versus moderate versus severe picture along anxiety, fatigue, and depression? And these were patients with either arthritis or lupus. And you can see here in this chart, the 50 is the US average. And then if I do this, we can see, for example, in anxiety that a 62.5 and any score above is overall the tick towards more moderate or even then a little further severe symptoms related to anxiety. In the article, the expert panels discuss that in decision-making clinically, that shift from mild to moderate really is a hallmark time for us to start thinking maybe we need more aggressive interventions with our patients. So just an example of how seeing a T-score and having some background kind of cutoffs really leads to us better interpreting those scores. So to give you an example, we actually use a lot of different benchmarks in our physical therapy and our primary care practice, and that helps us stratify for risk. As I said, there are some cut scores. So if we look at this readout photo on the right here, excuse me, we've got 5 different areas that we've tested this young child, or not so young child, with. I actually used an NIH Toolbox self-efficacy CAT, and then 5 PROMIS scores, including pain interference, mobility, sleep-related impairment, peer relationships, and anxiety. And to the anxiety example, we can see down here, the anxiety score is at 69.1. All right, so that well exceeds the moderate and even severe cutoffs from the MAN study. It also passes some other benchmarks as far as cutoff and concern that I'll share with you in a second. In this case, this child with pain, and I love the complete picture I get because the presentation was 7 weeks of pain, developing avoidance of activities in their sport, waking up at night, and the child actually asking, is my back broken? And there might be some narrative or story behind that. Likely there's something in the family. It's seldom that I ever work with a kid or a teen with long-term persistent pain that there isn't a family component perpetuating that. And so, but now I have this whole set of T-scores and I can run down the gamut and see, starting at the top, this kid has a high level of self-efficacy, more than average. Pain is definitely interfering at that 62.4, but they're still staying mobile. 53 is a little below the average for teenagers, but still doing fine. Sleep, even though he's waking at night, doesn't identify that as impairment. But peer relationships seem to be a problem too. So there may be some anxiousness about what's going on, and it might be affecting how they feel they're acting socially with their friends. And from a physical therapist perspective, that is solid gold information, whether it's in the outpatient clinic or in primary care, because that's a way different approach than me just saying, oh, your back hurts and it seems to be bothering you for a while. Let's do some physical stuff. I think this kiddo doesn't need physical intervention first. I think there's probably some work with the child and the family. There's probably some fear avoidance happening that we could work through, maybe even challenge some beliefs about what he can or can't do at this 7-week point. And then, of course, I could explore, even in the 20 minutes that I'm with him in primary care, I could explore, is there excessive muscle tension that we could just teach relaxation techniques around? Come back, see the patient in a week or two and see if they've gotten out and gotten a little more physically active, and then see what their beliefs are and actually administer the promise again. So cool case. I'll pause real quick in case there's any questions that want to jump out. I love talking about this stuff, by the way. I think promise is fun. And I think, the multidimensional way we work with kids is super fun. All right. Of course, promise also can objectively track changes. I said this before, having the computer adaptive test where 4 to 7 items are the most that are usually administered per measure makes it rather fast. Kids are a little slower than their parents, so parent proxy goes a little quicker, but still, that's amazing. As a general guideline, if you're looking at score and change, greater than a half standard deviation or greater than a 5-point change would be considered notable, like something's probably gone on there. And there more so in adults, but there have been some MCID and MID type studies around that. But I want to point out, I love this article. This is Roos and friends in, I want to say it was, okay, there it is, 2019. I love the title. It says it all. It's good to feel better, change, but it's better to feel good. And that's threshold, right? And so thinking of those cut scores, either from the MAN study or some other cut scores that we use, is it's great if my physical function, for example, goes from 30 to 35. But I started at 2 standard deviations below normal, and I'm still a standard deviation and a half below normal. And so that change might mean something to me. But we know, like in our adult populations, that if a patient gets their physical function above a 42 or 43, based on some research we did in primary care, then they're at that point where it just feels good, like it's no longer a main issue. And so as we think as clinicians about how we measure change, we should also think change is one thing, but achieving a certain threshold is another. And that really helps us as we think about the progression of our treatments. The other thing related to repeated measures is factors change over the course episode of care. That's definitely true in my practice. Something might bubble to the top at first that we kind of go after as far as their function or their life and symptoms, and then those get better and then other things come out, which I'm sure you've experienced. Here's an example of an EMR-based report. And so picture yourself as the practitioner, and the patient actually took the promise before they entered your exam room or wherever you're treating. And then this came up on the EMR before they walked in. And so you have this is an example of lead intel that's both the current time, what we took, and change over time. And so I love the way that kind of happens. And you can see decreasing pain in blue, increasing upper extremity function in purple, and then looks like they've thrown in a couple other measures just once. The changing factors thing, let's say we have a kid we're seeing around school performance, and we administer these for pain interference, anxiety, sleep-related impairment, and peer relationship. And the thing that bubbles to the top right away is sleep. So this child is definitely having trouble with sleep. But let's say 4 weeks down the road, that's getting that's getting dealt with. And sure enough, sleep-related impairments down to 50, so it's not an issue. But why is anxiety and peer relationships now at the top of the scale? And what led to that change? And so in addition to just changing or tracking progress, we see this a lot where different factors emerge as we continue on in an episode of care. So kind of fun. And then last, I'll leave the discussion with the factors that would be the ideal implementation in primary care for us as, whether we're therapists, behavioral health professionals, MDs, PAs, NPs, or anyone else in the medical home. The first thing is it being administered in front office as the patient's waiting to come in. And that gives, again, that separation so that they, in their own space, can give kind of their objectively self-assessed, unfiltered information. EMR integration is ideal. Right now in both our clinics, we have to manually enter the results from our iPad into the EMR, but I do get front office administration and immediate feedback, so that's good. Graphic longitudinal results, kind of like the last one I showed you, as well as this example up here. There's a couple examples we've seen around the country. Instantly available before the provider enters the room, and that's kind of that lead intel, so that you can walk in more equipped to really guide the conversation and also allow the patient to reveal biases and or discrepancies. And I guess that's it. So I can unshare if I can find a cursor.
Thank you so much, Ryan.
Yeah.
You have a question on the chat. If you can share how many questions and how is the selection happening?
Yeah, let me read through it here. Yeah, okay, so this is Jenny's, in response to Jenny's question. I can set up on that iPad app, I set up a participant profile, just name, birth date, and gender, and then any identifier we use in the clinic. And then I can select the measures, and I can do that each time. And then you can also, and we set up batteries of exams. So I have a standard pediatric outpatient battery of 4 or 5 measures. In primary care, adult, we only use 2 because it's super rapid and fast. And so then you can just select that, create a new assessment, and hit start. And then how many questions? Like I said, as computer adaptive, the fewest is 4. I feel like some of them go 7 or 8. The ones that go more than that, it's when the patient's either functioning really high or really low. Because the point of the IRT model is to start with questions that have broad span across the 5 Likert functions, and then select more narrowing and discriminating questions. But when it's confused, or when a patient says some things that are narrowing them towards high function, and then they say something really low function, the cat goes, whoa, wait, and then it has to go broad again and kind of ask. So cost behind the type of build out. All right, so the cost with the iPad is a $500 a year license for 10 iPads. And so iPads are about $300, and we have 10 of them. And so our total implementation was about $3,500, and we just pay the $500 per year. When you get into integrations in EMRs, from people I've talked to who do that, it could get hundreds of thousands. But there's also the in-between. In the ideal implementation, you have a workflow that works around your primary EMR, like if it's an Epic, and I forget, I want to say a couple others have it too. And then the cost is just your Epic maintenance cost and the workflow that happens with your front office and how that is translated to you. I think the translation is where IT departments in larger organizations come in, where they can create user interfaces that quickly shoot the results to kind of a face page in your EMR. But yeah, it can get fancy, and there's lots of people involved with that, and we're just not big enough to do that kind of thing. Let's see, any thoughts on comparisons between PROMIS and PHQ-9? Healthcare systems use both. So PROMIS actually there's a lot of data out there for crosswalks with existing care or existing measures, especially with related to health. There's a ton of work that's been done that actually loops it in for do you call it QALYs or QALYs, the QALY type calculation of morbidity and mortality. I forget her name, I've met her multiple times, where you can administer a subset of 8 different metrics that have shown to track really well with that kind of calculation. Yeah, so the integration is out there, and I'm pretty peripheral to it, but it is there. Healthcare systems that use both have resources, and they have invested providers because providers don't want to ever do any more, and I don't blame them. So, you know, the win and implementation side is when a provider can have something taken off their plate so that promise can be added on their plate. And then, of course, the value they get. Some measures captured on each of them. Yeah, that's true. You know, the struggle, I'll talk about this a little. The struggle with promise is it being agnostic to disease. So nothing's tied to a certain disease. And so disease specific questions are questions that we've found a lot of value over the years from other measures that aren't on promise. There's a trust aspect. And then if you dive deeper, the CAT's only choosing a certain set of questions based on your responses. And so it's really frustrating, especially for physical therapists who really like to have the details, to go back in and see which questions were actually asked and go, oh, but you didn't ask about this. Oh, but you didn't ask about that. And that's where, you know, the provider and any user needs to be sold on the rigor of the development and the fidelity to the IRT model, where a score of physical function, like in my world, of 41, it doesn't matter if they ask, can they, you know, run 3 miles with minimal difficulty? I know that a 41 reflects down to a person who is starting to show difficulties in their work, right? And so there's a letting go that happens with that. Would you recommend this? Rebecca says, would you recommend this type of assessment? Anticipate that you won't be able to use it electronically to start. Oh, you mean like to do it via paper? Is that true, Rebecca? Is that where you're going with this? So if you can do it on paper, you need someone or yourself to have enough time to input into a standard Excel spreadsheet, and then Promise has a scoring service. And you just go to the scoring website, input which metric you took, upload the standard kind of .csv file, and then it'll email you the results. It's hard to do. I mean, but you can do it. If you wanted to just start trying it with pediatrics, that would be the way to do it. And maybe it's something where you don't get instant feedback before the visit, but you can actually use it and see how it functions. And you can, I left my email in the slides, so if you want to email me offline, I can kind of connect you to where that is. In line with Jenny's question, we bill when we do certain standardized screening. Can you bill for this at all? Totally dependent on your practice. We don't in physical therapy practice because that's just how assessments go. It's not like our physician partners who have procedural codes for any ones. And I haven't heard if people are or aren't. Yeah, good question. Promise is more sophisticated measurement approach than a single screening measure. True for, okay, cool. Thanks, Julie. We also have a full 4-hour CME in May with our Promise experts at that. Oh, cool. Any other questions or thoughts or?
I had a follow-up question. First, I just wanted to thank you, Ryan, because we were so anticipating the Promise, and now we see its promise. No pun intended, but it's really exciting. And so I think this is kind of in line with some of the other questions and people are asking about, using it in addition to the PHQ-9 or some other measures. You had mentioned a bit about these kind of clinical cutoff scores. Mm-hmm. So you have like the T-scores, which we can kind of understand, okay, you have a standard deviation above, but I guess thinking a little bit in terms of how to, I guess, help with clinical decision-making, because some of the other screeners I think we're used to have kind of more, maybe it seems a little bit more clear cutoff, right? That someone's mm-hmm. reporting mild or moderate depression or ADHD scores are like this or something like that. And we know what to do with it. So how do you kind of suggest in primary care, are there other kind of mild, moderate cutoff scores you kind of alluded to that kind of help with clinical decision-making?
Right. The two ways that's happening in the literature, and it is more in the adult, but like that man study is one of the examples in children, is the one is, they do the kind of qualitative focus group cognitive interview thing and come up with those cut scores. And then the other thing that can happen, well, there's three actually. The second thing that can happen, which we did in primary care a lot, is we used a single pass question, a patient acceptable symptom state question with adults. And it basically says, considering your symptoms and your function and everything going on with your life, would you consider your current state satisfactory? And then we use the yes, no, along with a big cohort of T-score data, and basically just ran a receiver operator curve and came up with up to 80-85% accuracy on some of the measures for predicting, yes, I'm past yes, let's go, or no, across a given threshold. And I alluded to in adults that 42 had, I think, 79% accuracy for predicting yes, no. So that's kind of like using the single anchoring question. And then if you were, let's say you were going to use it with another existing metric that you love and the cut scores, you could run both. And I'm not sure, maybe studies have run both, and then looked at the cutoffs for that one and then triangulated that to the coordinating promise score. So you could do kind of it's like a receiver operating curve, only you have two continuous data points. I believe the website that has a lot of this is called Prozetta Stone, like Prozetta Stone. But you'd be looking for promise crosswalks, right? Where we've looked at cutoff points, and then they kind of map out those. Is that helpful?
Yes, thank you.
Okay.
Hey, Ryan, can I inject a couple of things here?
Please, definitely.
First of all, in a couple of weeks, I'll be presenting the results of the survey many of you took at the conference in Boise. And we found that promise is almost unknown in the general population. And so there's a lot of work to do there. That's why we're participating in this conference, and we'll go over this again in a couple of weeks. I think one of the barriers to adequate screening is the fact that people interpret the word screening to mean they've got to sit down with a patient and go through a checklist. I think we have to emphasize the fact that all of this screening is done outside of the clinical visit. And so the clinician gets the benefit without the investment of time that detracts from their visit with the patient. And that's a really important factor that I don't think is emphasized nearly enough. Is that, especially when I hear questions about some of the questions I heard this morning, it's almost like this is free information to the clinician. And it gives you a chance to add to what you know about the patient before you even see them. I can't emphasize enough how many objections I've heard from people who just don't have the time in their visit to do screening. So screening doesn't get done. So there's no longitudinal data. And okay, the other thing we're working on is outcomes research. What is an outcome? Okay. So Ryan gave you some very good examples of how we can start measuring outcomes using this tool. So I really want to endorse the fact that it's very beneficial. I also want to add that for communicating these test results with patients, in my company, we've translated the T-scores into percentile rankings. So to patient, if you tell a patient, boy, you're at the 80%, you're in the 80th percentile of people with severe depression, that has a physical reality that the T-score can't communicate to a patient. And it's a translation that's very, very standardized from the bell curve to the percentile ranking. And we do have an obligation these days to start feeding back to patients what we've learned. And so they do want to know, I took this test, what does it mean? So that's something. The last thing I wanted to mention is, in addition to the process, which is really super, because you never, generally speaking, never ask the same question twice, so the patients don't learn how to answer. Promise has published profiles, and they have a complete set of profiles for pediatric and for parents as well. These are different because they always ask the same question. And the validation is just as rigorous. And they generally ask a set of 7 questions, seven territories they investigate. 2 of them are mood and the rest are performance. And then they ask in this process, they ask the pain level. So this is better for population screening. If you want, because when we go into alternate payment methods, we have to have some baseline of the severity of our patient population. That's how they compute some of the payments. So you need population screening, and you need something that identifies the impact these different conditions have on your whole patient population. So PROMIS has got that covered too. I just want to emphasize that.
There was a
Thank you.
question. There was a
Yeah.
question about which scales to use with pediatric. I want to make sure because it's pediatric group. What scales in pediatric would you recommend, Ryan?
I saw that. Thank you for capturing that. What I would recommend doing is setting up batteries depending on the categories of types of patients you get. So in my mind, like if you have a patient who's got, pain-based complaints or MSK complaints, I'd want to know things like their physical function, mobility, their pain, how pain interferes, sleep related impairment, probably peer or family relationships. There's one for each to kind of look at that interaction. And then there's always anxiety and depression, which are nice. Or if you want a more positive spin, there's a positive affect scale, which is kind of the inverse. I mean, it's not perfectly the opposite of depression or anxiety. But when it's low, you can get a good sense because it really just asks, in the last 7 days, I've been happy, I've been joyful, I've been blah, blah, blah. And it definitely captures kids who are going to be blah, 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 and then you could hone in. On the flip side, in behavioral health, if it's not kind of physical pain focused, you might dive more into the mental social stuff and the ability to participate in social roles and that kind of things. If you're kind of diving in there aren't hundreds and hundreds of the pediatric ones. So jumping into kind of that intro site and picking what might be most applicable for a certain type of patient, then you just create a battery and you select that for your participant.
Ryan, there are a couple of questions about how do these questions get pushed to the patient ahead of the visits. And the other one is about overwhelmingly, everyone has a bunch of screeners that they use and give a patient to complete. And if there is some guidance about what would be the recommendation, obviously you're going to recommend that we use the PROMIS.
Well, I'll be honest. I mean, the reality of practice is I need what helps me make the best decision. And in times over the past 23 years where I've tried to elevate my ability to better do my job, I've had like a break in the craziness that is our lives. It takes a little time to invest. But my favorite example is actually Dr. Philbrook, who I work with as an orthopedic adult-based PT, and she spent 6 months administering all her favorites and the PROMIS ones, and then finally abandoned the favorites. And that 6 months took both kind of seeing it reality with patients and having time to get into papers that kind of show the relative strengths and weaknesses of each. And then there's definitely a letting go, right? The things we've always used to measure are the things we always interpret based off of. And so when something comes along and you see value and you test that value yourself, and then it's validated by evidence, and then you come back and at some point you abandon something, right? And we're all different in how quickly we abandon things. I happen to consider myself not necessarily an early adopter, but an early abandoner. And so that process was easy for me, right? And I'm an idealist. And so the idea that those kids and families who use PROMIS can tell me what they think objectively without me being there first really resonated with me. And so as far as recommendations to do it, yeah, I think PROMIS is great. But there's nobody in this room right now who's not making great decisions with the tools they're using. So,
Thank you, Ryan.
yeah. Are the scales, Lori asked, are the scales available to providers to determine which scales might be most helpful? before making a commitment to purchase. Yes. Here, I'll share my screen just so you can see this. So if I go to healthmeasures.net, which obviously pops up on all my browsers all the time, and then right up here, it has search and view measures as one of the 5 top options first. I can search not just PROMIS, but all of the other NIH funded type things, but I could choose my age. And so in this case, I'm going to choose what's available for parent proxy report for pediatric. I could narrow it to one of the 3 categories, but I'm just curious about all. I could even narrow to domains within those categories, but then I'm going to go into the measures, and there are computer adaptive item banks, and that's where I would start. Or you could search for, like Dave said, for batteries or profiles that are set for the same questions, similar to short forms. But I always grab the computer adaptive test, and since we're talking PROMIS, I choose PROMIS, and then I just hit search, and here's the best part. Tons, right? And I can just kind of scroll through and see them. Here's depression. If I click on depression, I have access to the entire item bank that the computer adaptive test will use. And it downloaded immediately to me for PDF. And then now I have a PDF that tells me every possible question that item bank will ask from. And it won't ask all, but here they are. And these are the total questions that were asked. And that really helps with previewing. If I do a short form, it does similarly. So I'll stop the share there now. Is that helpful?
Awesome. Thank you so much. That was helpful.
It is the benefit of a publicly funded initiative. I mean, yes, our universities are the center of kind of validation and development of individual measures, but to develop a PROMIS measure, you're beholden to the same kind of like, let's get this out there thing.
Don't stop the questions, put them on the chat if you don't want to unmute, but for the sake of time, we're gonna move on to the research corner, and then we will have more time for discussion. Jonathan, are you ready?
Sure. Well, thank you so much, Ryan, for presenting. He really did a great job. I'll just kind of chime in. I actually had it prepared for the MAN article, or MAN article. I'll share my screen there just to show you guys how these clinical cutoffs were determined. Let's see. I'll be real quick. I don't be mindful of time. So basically, it looked prior to this, there hasn't been too much work on allowing for meaningful interpretations of PROMIS pediatric T-scores. So a group of rheumatologists basically identified these clinically relevant juvenile arthritis and childhood lupus categories or domains. Participants included children, let me see, I have it right here, included adolescents, children, caregivers, and the rheumatologists. They reviewed vignettes, much like this is a T-score of 45, a T-score of 40. And they basically rated these vignettes. What was this no problem, mild, moderate, or severe? This next table kind of captures that. And you kind of see how they all bookmarked, you know, what the severity of this vignette was. And basically the result was that across all the participants, they placed the bookmarks with a high degree of similarity, sometimes even with perfect agreement, both within and across groups. And like Ryan showed this slide, as you know, the 50 is right here, so you can kind of see these breakpoints of different severity categories. This slide's really interesting because it really gets into the data here. And it's in terms of interpretation, you can see, for example, if someone with, you know, if you want to look at anxiety, if they score with around a 52.5, no problems to mild, probably don't have to do anything. However, as it increases and it gets to the 62.5 or 72.5 from moderate to severe, then again, as Ryan suggested, likely an intervention would be necessary or helpful. And as you know, moving forward, I think a lot more research has to be done on this. Across other populations, diseases, health conditions. And as a discussion we're about to have and it's kind of started, you know, how can this be used in pediatric care? How can this be used in clinical decision-making? And if you are using it, how you're interpreting the scores. I think Dave had a great idea about how you look at the percentiles, but I think more research around this qualitative interpretation is necessary to determine these cutoffs here. All right. Thank you.
Wonderful, Jonathan. Thank you. Any more questions, comments? Is anyone here using the promise that hasn't spoken yet?
Using it, I just had one other question, and thanks so much for that awesome talk. That's really interesting stuff. And when I think about some of the other screeners, sometimes, for a particular, thing that you're screening for, it'll look at symptoms and then the functional impairment that may be associated with those symptoms too, kind of all in one. And I didn't look, I can look more through those question banks, but are most of the questions symptom-based, or are those T-scores representative of kind of functional impairment associated with those things as well? Or are there certain functional impairment, questionnaires that you typically incorporate in? And you were talking a lot about kind of the brief, or some about the brief act at the beginning in primary care, and that, focuses, maybe prioritizes functioning even over symptoms. And so just wondering kind of how that plays in, and what kinds of outcomes you might choose to measure.
That's awesome. Because each promise scale having a very unidimensional trait will give you what you need. And so obviously physical function is a function-based one. There's one called pain severity, and so that's symptom-focused questions. But the pain interference is, how does it interfere with your daily life? So all those questions tend to be like, my pain prevents me from doing my chores or stuff. But each of those will be overall very unidimensional, whether they're more symptom or function focused. And so choosing them, I think, would be getting into those CAT item banks like I showed you to download, and saying, aha, this is gonna help me with my brief act, because this is all about leave it behind. Let's talk about what our next step is, right? Does that help?
Yes, thank you.
Yeah.
Anyone else with questions, comments, experiences? Thomas.
I had a thought when Jonathan was talking, that if you were to implement and start using Promise, with all your patients, I would highly recommend adding a single anchoring question that's really applicable to your patient population's function. And that could be like a yes/no question, like I said, the past question. It could also be a 3 or 4 choice question. But if you were ever to then, get 6 months or a year down the road and decide you wanted to kind of dive into that data, you would have a range of promise scores, and then you could actually threshold that anchoring question that really means something in your practice and say, who falls into the okay answer on that single question, like what score ranges, and which score ranges on promise often fall into the not okay answer to that anchoring question. And you might come up for your own population within a year, kind of a cutoff for the major promise measures you're using. Yeah, once we get above 63 on depression, that's when this really kicks in. Or once social satisfaction with social and peer roles drops below 37, that's when I'm really seeing the patients answer no or bad answers to the anchoring question. Just having that in your EMR in case an intern comes along and wants to do a lot of data mining and stats is really helpful. Oh yeah, let me, Julie says, can I repeat the past question? There's a wide variety. There's actually one in pediatrics used in juvenile idiopathic arthritis. So let me search that real quick. Got the paper up. Here we go. I know I highlight it because I always want to know what they ask. All right, so this is considering all the ways your illness affects your child, so this was asked of the parents, would you be satisfied if his or her condition remains stable or unchanged for the next few months? So that's a little different. In an adult population, the most common one is considering your pain, your function, and how it affects your life. Would you consider your current state satisfactory? And so those would be 2 different examples of anchoring past questions. Is this an acceptable amount of symptomology or lack of function? And I'm sure in each of our practices, we have other kind of like global single questions that we could kind of triangulate with our promise.
Well, it sounds like, I don't know if there's any other last minute, we have 2 minutes remaining, any other last minute questions or comments, but I think this has been really enlightening. And I also just wanted to comment on your last part about the research. It's kind of really exciting. I think that's where kind of my mind was going with this too. There's really lots of opportunities to kind of track your outcomes with this measure. So I think she's put in the chat that there's kind of 2 announcements that our SIG meetings are actually moving to the first Monday of the month as opposed to the fourth Monday. So our next membership meeting is actually going to be on the 6th at 12 Eastern time. And Dave, whom I don't know, he is still on here. Yes, he's going to be presenting the results of the screening surveys that he had alluded to earlier. So
in particular, this pediatric portion of the survey, and a little
Yes.
contrast with the adult section.
Awesome. So thanks everyone for your engagement, for showing up today. Thank you, Ryan. Thank you, Jonathan, for the presentation. And we will see you all next month.
Really appreciate you all. Thank you.
Thank you, Ryan. Thank you, everyone.
Thank you, Ryan.